Welcome to the second of our Teens Live learning events for this week. I hope that you enjoy the session today. We're going to start with Professor B. Wee, who is the National Clinical Director for End-of-Life Care. Is a consultant in palliative medicine for Oxford University Hospitals NHS Foundation Trust and is an associate professor at the University of Oxford.
Thank you. So hello everybody. Alexa, Dr. Clark asked me to speak a bit about the National Palliative and End-of-Life Care Programme, for which I am the National Clinical Director for NHS England and NHS Improvement. So if I could have the next slide, please. So these days, we can't obviously start to talk about national policy and programme without talking about the policy context. So the policy context slide is really just setting out the way in which things have changed over the last 10, 12 years. So the National Strategy for End-of-Life Care, which was the first national strategy, was published in 2008. And then there was a relatively stable period for 5 years when you could kind of get on with looking at the strategy, trying to implement it. And of course, many parts of the country got on with doing that. And that was the National Strategy for England. And then what happened was two things that happened in parallel, which were pretty big things for the world of end-of-life care. One was the Health and Social Care Act came in 2013, which completely changed the way in which we deliver, or rather we commission and deliver our care. And we had a different health and care landscape, which you will all be familiar with. Seems a long time ago now, but it was only 7 years ago. That same year, about 3 months after NHS England came into being, and about 3 months after I took up post as National Clinical Director, Julia Neuberger and her panel, her independent panel, reported on More Care Less Pathway, which was the independent review on the Liverpool Care Pathway. That followed then a series of different changes. Our response to More Care Less Pathway was called One Chance to Get It Right. And then in 2015, we set out the blueprint, which really builds on and replaces the national strategy of how do we improve palliative and end-of-life care for all conditions, all ages across the whole country. So that's the kind of policy context that's worth keeping in mind. And of course, then this year, we've had the COVID-19 impact, and I'm going to start with that. So if I may have the next slide, please. I thought it would be helpful to talk a little bit around what we've done around COVID impact. So the COVID Wave 2 objectives were fourfold. The first was to make sure that we had business continuity for both existing and new patients who require palliative and end-of-life care, including those whose needs have become more complex since the first wave of COVID-19. May I have the next slide, please, the one that's headed Wave 2 objectives. This ensures that the second objective was to ensure that the system was ready to scale up and re-intensify the care and support needed, not just for patients, but also for families and for staff, because we recognize the increased complexity of bereavement support that was required. The third objective was to make sure that as we started looking at recovery plans, that this prioritized activity that keeps our focus and our resilience on maintaining a really strong focus on high quality, personalized palliative and end-of-life care throughout the second wave, through the winter, and make sure that we pay attention to our equality duties. And finally, because we recognize that this wave was going to be at different intensity in different parts of the country, that we were ready to provide that additional targeted support where this was needed. Next slide, please. So the next slide is an infographic which really summarizes the various ways in which we have responded to COVID-19 from the National Palliative and End-of-Life Care Programme perspective. So that should be on the next slide, please, which demonstrates some guidance that we've published, but we have tried to keep that fairly limited because we recognize there's a lot of guidance out there and people are too busy to read much more about it. Importantly, we focus a lot on communication, on two-way communication, hearing what's happening, but also communicating and sharing information. One of the ways in which we did that was that we started running webinars, initially weekly and then changing to fortnightly, and we're continuing to run those webinars. They're usually COVID focused on palliative and end-of-life care, but obviously broader than that as well. And these are run at 4 o'clock, between 4 and 5, on alternate Thursday afternoons. So if anybody is interested in attending these webinars, but haven't found their way to that yet, I'm sure we can organize for you to be enrolled on these. There's been a lot of parliamentary questions on matters relating to palliative and end-of-life care, and a lot of focus around how do we support hospices to continue to provide capacity for managing COVID. We have an end-of-life practitioners network that went from about 300 members at the beginning of March to over 700, in fact, it's higher than 771 now. And this provides a great forum for people to share information, but also to ask questions of each other. May I have the next slide, please? So if we just go back to the policy context, I'm just going to take you back to, if you like, where things are sitting. So we'll actually scoot past the next slide again to the one with the multiple arrows, please. So in this slide, it's really wanting to demonstrate to you the number of ways in which we have looked at the multiple reports that came out from first of all, the national strategy, but then I'll move on to the next slide, please. But then also the multiple other reports that came out, including a Health Select Committee report during that period of time. What we recognized we needed was that with all these multiple reports, we needed to pull that together into something that was coherent and provided a national steer, recognizing that the health and care landscape was now very much around how do you drive things locally rather than how do you try and drive things from the center. So what this does show is that what we've got is the ambitions framework, which I hope many of you will be familiar with. This is a national framework for local action, which has one kind of unifying vision about I can make the last stage of my life as good as possible because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. That is a very important unifying vision. And we identified 6 ambitions which will help us to achieve that particular vision. And those 6 ambitions are very much outcomes-based and recognizing that we go from the focus on the individual through to the community needing to be prepared to help, but also staff needing to be prepared to care. Alongside the ambitions framework, the other bits of policy context are that there was a 6-point end-of-life commitment, which I will come to in a minute, but also the NHS long-term plan and the universal personalised care, which was a significant part of the long-term plan, are all important policy context for us. Next slide, please. So this next slide actually demonstrates the 6-point end-of-life commitment. The government, at the time, you will remember Andrew Lansley was talking about no decision about me without me, and therefore DH commissioned some work on what was the choice commitment around end-of-life care. And they published this 6-point commitment, which in a sense amplifies the 4th ambition. And the commitment was that as you approach the end of your life, you should be given the opportunity and support to have honest conversations about your needs and preferences, to make informed choices, to be able to develop and document personalized care plans, and obviously within that is also to review and revise, to be able to share that plan with care professionals, and to be involved to the extent that you wish, family, carers, and those important to you. And finally, to also know who to contact if you need help and advice at any time. So that is an important background policy context. And although I'm talking about things that were published in 2015, 2016, they remain incredibly relevant for now. Next slide, please. So I want to say something about, so why do we need to change? Why do we need to continue focusing on end-of-life care? In England, over 500,000 people die each year. Obviously, this was an unusual year and excess deaths will be considerable. But even behind that, as a baseline, the number of deaths each year is expected to rise by 17% by 2030. Now, we know that some of these are obviously unexpected, sudden deaths, road traffic accidents, etc. But at least 3/4 of those deaths that I've just numbered can be expected. So we have an opportunity to plan. And we plan so that people can live as well as possible until they die, and to be able to live the life they want as far as possible. We also know that there are a lot of emergency admissions for people in the last year of life, and this is particularly true in the last 3 months of life. The Foundation Trust has done some work on looking at the cost of care, and they will show very clearly that hospital cost of care goes up significantly in the last 3 months of life. But if you look closely at that data, you will see that the increase is due to emergency admissions rather than elective admissions. I will argue that there is always a place for elective admissions for people right at the end of life, whether that's for symptom management, for palliation, or some people simply do not want to die at home and would prefer to die in hospital. But emergency admissions are something that we should be aiming to reduce, because firstly, they're not particularly great experience for the person. They're not particularly great experience for those who are close to them. They cost the system a lot. And whilst we cannot prevent all emergency admissions, we may be able to reduce them with advanced care planning, with anticipatory medication prescribing, with a sort of a proportionate and appropriate response when urgent, unscheduled, unexpected needs arise. So all of those things are things that will help us to reduce the emergency admissions. And one of the markers that we use at the moment to compare between CCGs is the proportion of deaths where there has been 3 or more emergency admissions in the last 90 days of life. So following COVID-19, clearly there's a significant increase of people who continue to live with long-term conditions, palliative needs, and we really know very little yet about the longer-term impact of long COVID, and whether that is a chronic condition for whom some people will recover and some people will continue to be chronically ill, whether it becomes an advancing condition. We really don't know any of that yet. What we do know, and especially I guess for you guys, is the fact that people with cancer are presenting with very complex problems at the moment, some of which has been because they have held back presenting themselves. Some of it is because there's been less healthcare professionals out in the community. There's been less family around to spot them. There's a whole variety of reasons that we have yet to unpick and understand. But the fact of the matter is there is an increase in needs and increase in complexity right this minute. The CQC review, which is a little while ago now, highlighted inequalities and inequity in care and access for certain groups of people. So we already need to change and improve things for the mainstream group of people. For others who are underserved, the situation is much more dire. And we have unsustainable commissioning models that really do need to be developed. So what are we doing about it nationally? May I have the next slide, please? This next slide simply describes the way in which we have organized ourselves. So we have on the right-hand side of the slide, which I hope you can see, even though it's not yet on my screen, on the right-hand side of the slide, we have our work stream steering groups. We have organized 6 work streams, or organized our work into 6 work streams. Clinical excellence, a digital work stream, workforce, a work stream on commissioning as an enabler, stakeholder engagement, and patient experience. So those are the 6 work streams. We also have on the left-hand side of the screen, you will see that our delivery model is through the regional networks. So we've got the regions, and each region now has a regional clinical lead. There is a regional network manager and a regional senior responsible officer for end-of-life care. And they are really the ones who are driving forward a lot of the improvements in end-of-life care. The workstream steering groups that are on the right are at national level, things that we might only need to do once for across the country, or that supports development in one or more parts of or one or more regions. And both of these report into the operational board, which is really the engine room, and our governance is through to the National Programme Board, which is cross-system and is chaired by James Sanderson, who's the Director of Personalised Care. And then we continue to maintain a very strong and tight relationship with the Ambitions Partnership. As I've said, there's about 37 partners now from across the country. They're national organisations covering social care, arm's length bodies, royal colleges, regulators, third sector charities, and so on. So there's a lot of people who are involved in that Ambitions Partnership. May I have the next slide, please? So that's the way I've just described is how we've organised our programme. And of course, the purpose of all this is to make sure that we can address the quadruple aim. And again, I hope you can see on the next slide, the quadruple aims are about improving health and well-being, as well as improving the quality of care. We expect the clinical excellence workstream to be contributing to both. We expect the patient experience workstream to be contributing to improving quality of care by understanding the person's experience of care. And the commissioning workstream, which helps with the financial sustainability, the workforce workstream, which is obvious around improving staff experience and well-being, and the digital workstream, which in a way feeds into all those areas, but particularly around helping us to improve health and well-being and to look at inequalities. All 6 work streams have got 3 underpinning principles, which is that they involve working with people with lived experience, that they cover all age groups, and that they seek to reduce health inequalities in everything they do. If I may have the next slide, please. So this next slide, just again, is a busy slide. I don't expect you to read the detail of it, but it simply sets out our 6 work streams and some of the projects that we are doing within those work streams at the moment. Obviously, with the second wave of COVID, we've had to pull back on some of that and to step back and deprioritize some of that work, not least because the colleagues we're working with are at the front line and are much too busy to be trying to move some things forward at the moment. But there are some things that we can progress quite well. So for example, in the clinical excellence work stream, we have managed to publish on a tool called the Early Identification Tool, which has been developed by colleagues in the Northwest and in London, which helps GP systems to identify people who are likely to be in the last 12 months of life. We're doing a lot of work at the moment around syringe driver capacity, which is obviously a priority as well during COVID. In the commissioning work stream, there's a lot of work going on at the moment, and pilots are about to start to look at different commissioning models that will support palliative and end-of-life care in a sustainable way going into the future. That's at pilot stage at the moment. I'm going to skip to patient experience, where we're actually looking at developing the methodology to be able to secure experience and feedback of people for whom English is not their first language. Clearly, this is partly driven by the experience in COVID at the moment, but also because we felt that if we were able to reach a group that is harder to reach, then the bits in between will be a lot easier. And these are people who might not routinely respond to questionnaires or might not have access to them quite as easily, whether digital or paper. And if we don't get feedback from certain groups of people, then it means that we are building our services and improving our services in a way that may not be meeting their needs and may be disproportionate. So that's why it's really important that we look at all groups. And then at the bottom of the slide, you'll see that we've said regional palliative and end-of-life care networks, because as I said earlier on, that is our delivery model. And of course, with the development of integrated care systems, that's going to become ever more important that we work through our regional networks. That brings me to the next slide, please. So the next slide is about the regional palliative and end-of-life care networks, which brings together both statutory and third sector partners who are in that particular region. And I've already talked about who they are, and the aims of the network is to develop that shared vision, that clarity of purpose that reflects those priorities at regional level. and we have got mechanisms in place that help the regions to learn from each other. We've also established a relationship manager from within our national team for each region so that we can help to move that development even faster. And there's been a huge amount of work done in the last few months and been impressively progressed during this time. May I have the next slide, please? So I just want to finish by reminding you of what are the benefits of all this. So importantly, the benefits to people are that, you know, our 6-point commitment for end-of-life care that the government said wanted to happen, needs to happen. So people are invited to have these honest, personalized conversations over time. So it's not just one big conversation, but multiple conversations at their own pace, that they're able to make informed choices through shared decision making and through really using language and that is suitable for somebody and that they can understand and that they have plenty of opportunity to ask questions and clarify. And that as a result of this, we're able to help them develop, document personalized care support plans, and that these are used and honored when these are required. And in order for the plans and the content and the person's preferences to be used and honored, those plans do need to be shared with care professionals. And also that they involve, to the extent that they wish, their families and those who are close to them. And finally, as I said earlier on, knowing who to contact and how if they need help and advice. It seems such a simple, basic thing, but it's one that causes huge distress if you don't know who to contact and you don't know how to get help and advice at a time you need it, which is often not usually in the middle of the day of a weekday. That people receive care that is proactive, that is coordinated, and that's responsive to their needs, and that they're able to live well at the end of life, even if they're part of an underserved population. And then my final slide is about, well, so what does that mean to the system? We think that achieving this means to the system a reduction in emergency admissions to hospital during the last 90 days of life. I've already explained why that is not a desirable thing, to have emergency admissions, if they can be avoided and if we can do something to prevent that. About the other bit of benefit to the system is identifying significant family members, informal carers, so that they can have an assessment of their needs and actions are taken to address these. Not only because we rely on these carers, especially the unpaid carers, to be providing a lot of the care, but also because there are long-term consequences for their physical and mental well-being. We will be able to improve staff effectiveness and morale through them feeling that they have a greater ability to hold more meaningful conversations and to deliver more coordinated and personalized care. And we do know, don't we, that when people, when staff have difficult conversations with patients, with families, or conversations that don't turn out well, actually they have not gone in there to have difficult conversations. They have been in a position where they have felt out of their depth, or that it's been just difficult to give the information clearly because they don't necessarily have the clear information themselves, etc., etc. So it's really important that we're able to start to support and help them to learn and based on their ambitions for palliative and end-of-life care. So that is really very much a bite-sized approach to of learning about the National Palliative and End-of-Life Care Program, what we're doing now during COVID, what we have done in the past to get to here, and actually what we're hoping to do going into the future. And with that, I will draw this to a close. I'm very happy to take questions. Thank you.
Thank you, Professor Beery. Shall we do some questions now then? Because I know Adrian in particular has a question, and if I can encourage any members of the audience to place some questions or comments in the chat. So I'll hand over to Adrian, who I know has a question for you, Professor Beery.
Hiya, Bea.
Hello.
I did have a question, but then you sort of covered it, but I'm still going to ask part of it anyway.
Okay.
You know, and I know you'd spoken about the use of survey and and the replies you get back highlight some of the groups of people that are difficult to access.
Yes.
And so, you know, and you talked about using surveys to engage, but I just wanted to ask what strategy will be or has been used for gaining insight into the patient and public views, you know, and what will take place to actually measure the impact of, you know, these new initiatives we are putting in place. And I know you've talked about the 90-day waiting times, but I just 90-day admissions into hospital, but I just wondered if there was anything else you were using.
Yeah, it's a really difficult one, isn't it?
Yeah, I know. I think that's why I asked, because it is such a difficult one.
I think that's right. You're absolutely right. And I think it's difficult because we have to be careful that anything we measure doesn't drive poor practice. And that's why we're very careful, for example, when we talk about emergency admissions, we're talking about emergency admissions that are avoidable and unwanted rather than all emergency admissions. So we always have to be really careful when we start talking about metrics. However, apart from metrics, there's also the issue of what's the experience like. And that's really, I think, what you're getting at there.
Yes.
And of course, in the past, we had the National Survey of Bereaved People, the Voices questionnaire, which is currently not happening because we have not been able to resolve some safeguarding issues around it, around the issue of anonymity and so on. But also, even when we had it, while it was very reassuring to provide a benchmark, we were really conscious that there were people who were not responding. So we were getting disproportionate numbers of responses from people with certain conditions like cancer, but certain other groups we weren't hearing from. We were hearing from, you know, certain major mainstream groups, but we were not hearing from people, if you like, at the edge, as it were. So we always knew that we needed to find more creative ways of getting some of that experience. And that's really what we're working on. I think in the longer term, what we hope that patient experience workstream will deliver is kind of a toolkit approach so that we can develop and identify, because some of these are already in existence and being used in parts of the country, almost a repository of different approaches to being able to gather this feedback. Now, the group I've talked about there are people for whom English isn't their first language. Clearly, just translating questionnaires is not the answer, at least not initially, because we're probably still not reaching people for whom just a questionnaire isn't going to work. So it may be through focus groups, it may be through a different approach. I honestly don't know yet. That's really why we're embarking on this work. And we're working with organizations that routinely work with these population groups to try and, I suppose, try and get at things from people's perspective rather than our perspective. Doesn't really answer your question, Adrian, but I hope that kind of gives a little bit of insight.
Very helpful, actually. Thank you, Bea. And actually, we do have another question from the floor from Jane McFarlane, and she actually, we've got two questions now. How can the voluntary sector contribute more to the overall aims of the programme?
So I think the voluntary sector is already a very significant part of it, because obviously they are part of the ambitions framework in terms of the national charities, the third sector organizations. And of course, at local level, voluntary hospices and other local charities are a really key part of how you deliver improved palliative and end-of-life care locally. That's why that sixth ambition was about each society being prepared to help. And that happens differently in different places. But I do think that they are critically important. You know, they're just key partners to what we do. And we talked about three pillars. There's things that NHS England, the NHS, if you like, the statutory healthcare bodies need to do. Then there's another pillar of stuff that we need to do with our statutory social care partners, for example, and local authorities. And then there is a third pillar, which is around the work that we need to do in partnership with the third sector, with the voluntary sector. And those range from not just care, but also being able to influence people, being able to encourage personalised care support planning conversations, through to bereavement support.
That's lovely. Actually, we've got some quite thought-provoking questions here. One of them, two have come through with respect to the impact of COVID, and
yep.
you know, and really just your view on, has COVID prompted more people to have these difficult conversations?
Right.
And I'm sure you can give us that perspective from a national point of view, and we do probably have a regional point of view on it as well. So, but I'm going to leave this
sure
to
you
you,
do.
Bea.
Yes. Yes, in some ways you have a greater experience. Sadly, you have a greater experience of all this than I do even. Has it prompted more people to have these conversations? I think it has. I think it may have scared some people off too. But I do think that, if you like, death and dying as a reality has been very much on the agenda, and people are very conscious of it. To a certain extent, I think it depends on the environment they're in, the family they're with, in terms of the conversations they have. We've tried to encourage it, because we've tried to, we have actually published a sort of a template, which is sort of an advanced care planning template, but it is specifically around COVID, but more around thinking about what happens if you get suddenly ill. You know, what do you need to think about in advance, those sort of things. Whether it has prompted people to have much more profound conversations, it's really hard to know. I think those of you, certainly I know with the patients I look after, that yes, it has, but it has also scared some people off having any conversation at the moment, because people are just so panicked and tired. But you'll know, you know, I think everybody in the audience will have their own stories on that one. On the national perspective, I completely agree. I mean, it is not possible to live life as we know it right now. That is just how it is for everybody. I think the vaccines obviously is a really good news story, but it's really important that we don't throw it all out the window right now. That you know, this is the time to be really, really careful, so that we don't have one unnecessary infection than we need to have as we head towards a more sort of a vaccine-dominated world, really. But it's going to be some months, isn't it, before we're at that point?
Yes. We have actually got one more question here, and I think it is the kind of question that crops up all the time, and it is how can we avoid a postcode lottery for good end-of-life care, and should it be a basic human right? And I'm sure the national, you know, it is that question that does come up, and I'm sure it is the mainstay of why we do this work.
Exactly. Yeah. It is. I think, should it be a basic human right? Yes, I think it should. But of course, I would say that, wouldn't I? I think I suppose it's really about kind of saying, how can we make sure that people have the very best of end-of-life care? And by that, I'm not talking about just the last days of life. You know, obviously, I'm talking about the last year and years of life. How can people live as well as they possibly can right up to the end, and that the end is good, and so on? How can we avoid a postcode lottery? I think by really aspiring to the standard. So then, you know, there's various things like the nice quality standard. There's the ambitions framework, things that we're trying to aim for. But I think what's maybe a subtext for that question is, how do we make sure that it is well commissioned and fully commissioned wherever you live in the country? And that's a harder nut to crack, but we are trying to come up with things like commissioning frameworks, really to guide commissioners around, you know, what do you need to make sure is in place. And to that effect, we are currently piloting two service specifications, one for children and young people and one for adults, which describes what that service should be, that should be commissioned. And that's probably the best way we can from the centre to try and influence that. Obviously, for people who are delivering care at the coal face, is making sure that whoever's in your postcode receives the best possible end-of-life care.
Thank you very much for that. I'm looking at the. Oh, we've got Annie. has sent a message, and she said it's good to hear that community organisations are being involved in patient experience, and I think we would all echo that. So yes. Thank you very much. Jo, should I hand back to you?
Yes, thank you, Adrian. Professor Beery, just thank you again for the presentation. It's been a really great insight and to know about the plans, and I think you answered all of those questions really comprehensively. Thank you so much.
Thank you for inviting me, and I leave you in Alexa's great hands.
Lovely. Thank you so much. Thank you, Professor Beery. Goodbye.
Bye.
So I would like to now introduce Dr. Alexa Clark. Alexa is a consultant in palliative medicine and clinical lead for the Northern region. Again, I'd just like to remind you, we've got the chat box, so please feel free to make any comments, leave any questions for Alexa that we can do at the end of the session. Thank you very much, and I'll hand over to Alexa.
So that was a fabulous talk from Bea, and what she said, what she's done is set the scene nationally. So now I think we're all attendees from our local region, and we need to think that how we can roll out what's been led nationally and down into our region. So if I could have the next slide, please. So what do we have in our region? So we have a north of England, a North Cumbria supportive palliative and end-of-life care network group. And as Bea has already said, that I'm the clinical lead working 4 hours a week. I'm supported by the program lead, who's Tracy Wilson, fabulous admin support from Naomi, and of course support from Adrian Moffat, our delivery manager. And when Bea talks about our region also covers Yorkshire, and we have a clinical lead, Charlotte Rock, down there, who I work very closely with. And our task is to deliver and to support the delivery of palliative care across our network. So how do we do this? Well, we have a group, and the group is representation from all 11 localities, from out of hours, the ambulance service, out hours, doctors, paediatrics, social services, a patient rep, and multi-professional. It's been important. We have doctors, specialist nurses, AHPs, managers, commissioners, GPs. So we have lots of representation, we feel, from across all groups and across all areas. And we get together every 3 months. That used to be in person, and more recently it's via Teams. And we have had some more extraordinary meetings during COVID. And these groups, we share best practice, we support each other, and we have task and finish groups for specific network projects. And I think when someone was asking about COVID and how we've managed during COVID, we've been asked a lot of our tasks during COVID have been to cascade a lot of information down from the national team. But we've also looked at what best practices have been going on throughout our region at that time and shared that within different localities. And I hope that's been very supportive for everyone. Next slide, please. So I talked about our task and finish groups and what our network has been doing. And I just wanted, I'm not sure of the delegates. I was given a list a few days ago, and obviously it's been updated since then, but it's just to highlight some of the work when Bea talks nationally. I'm really proud that our region is already, I think, meeting quite a lot of the needs from the national team. And I think our region has been ahead in quite a lot of the areas so far that Bea's been talking about. And when I've been attending these meetings, I can see that we've been ahead in a lot of ways. So one of the ways we've been ahead is that we have promoted advanced care planning for many years. And many of you will be familiar with the Deciding Right suite of documents. And this promotes individualized care planning. And it was the idea of Claude Regnard many years ago, who's actually since gone on to design the Respect Form. Previously, so this came about because he realized, first of all, that lots of different organizations were using lots of different forms. And when people move from one organization to a next, often the information had to be rewritten. But he actually promoted the idea of advanced care planning. And I think someone was asking on there about during COVID, Pete and Bea was answering one of those questions about advanced care planning during COVID. And I have to say that in our region, we found there's been a greater use of a lot of these forms during COVID. And I think healthcare professionals within our region have really embraced the idea of proactive planning for patients and introducing conversations early so we can ensure that we have individualized care planning for everyone. So deciding right, the guide to making individual care decisions in advance, and it comprises of 4 documents. There's an advance statement, an advance decision to refuse treatment, which would actually be completed by a patient, and the do not attempt cardiopulmonary resuscitation, commonly known as DNA CPR, an emergency healthcare plan that would be completed by a clinician, by a healthcare professional in discussion with patients and carers. As I say, they're recognised by all healthcare professionals across our area. We also have a website and an app which the network has made sure that it's been updated to reflect up-to-date information as it comes out nationally. And there's lots of information on the website, including patient leaflets. I have to say a lot of this work was done by Claude, and now when we talk about a network group, we have a Deciding Right educational group led by Louise Watson, based at St Benedict's, and I thank them for leading a lot and continuing to help us update this and provide a lot of education resources around deciding right. Next slide, please. So to go into detail, so advanced statements and advanced decisions to refuse treatment are perhaps used less commonly, but the forms that people might be more familiar with will be the emergency healthcare plan and the DNA CPR. So as I mentioned, the emergency healthcare plan, that's written by healthcare professionals, but in consultation with patients and carers. And it's encouraging people to consider advanced care planning and personalised care. The document, it should document and should be asking patients and their carers what would they like to be done, but what they also may not want doing. And can I just emphasise, it's about treatment in the community, and it's also about escalation into hospital. And I do emphasise that because I've heard some people having a misunderstanding that this is about how we keep people out of the hospital, and it certainly isn't. This originated in a paediatric population where parents wanted to know what they could do to care for their children in the community, step 1 and step 2, before they escalated them into a hospital. And so it's certainly for many patients may include escalation into hospital, although it is also equally useful for patients who decide that they would like to stay at home, and a plan should be written on what they should or shouldn't do at that time. We have noticed an increased completion of these in the COVID pandemic, as I say, to reflect more conversations with patients, and I think also to reflect that we're aware that more staff may be off work during this pandemic, and it's really important that information that's important to the patient is documented so that all healthcare professionals looking after them will know what they want, to save repeating conversations and make sure we've written down what the patients, carers and community staff should do. And for these to be completed well, they should write down what their patient's wishes are, but also a plan, first of all, for the first healthcare professional or for the patient and carer, what they should do in case of emergency, then what the next visiting professional should do, such as a district nurse or ambulance services, and then what the next visiting healthcare professional should do. We have planned already to review the content of that, and as a network group, we're currently reviewing this, and say led by Louise Watson and the group at St Benedict's. Our network group is a multi-professional group, again from all localities, and we're actually just looking, there's been some really excellent ones written during the COVID pandemic. We're looking at areas of good practice, and we plan to actually digitalise this document so it's easier for use, and we're have been helped by many GPs across the region with this and the digitalisation group, so it will make it easier to fill in and easier to share. Next slide, please. This is the DNA CPR. As I say, that stands for Do Not Attempt Cardiopulmonary Resuscitation. And again, this is a regional document that was brought in and introduced to ensure that the same document is used across all care settings. Please, can I just note that this is Do Not Attempt Cardiopulmonary Resuscitation. And again, there can be a misunderstanding by some patients and healthcare professionals that it means no treatment at all. It certainly doesn't. It just refers to cardiopulmonary resuscitation. And any conversations around this should be introduced as part of a discussion about what treatments patients would want and would be appropriate, and then introduce this to ensure that patients don't receive any inappropriate interventions at that time. And in the case of a cardiopulmonary arrest, they're allowed to die with dignity, with a focus on comfort. I'll just bring up here, because sometimes people ask if we've introduced, I've heard of respect, and ask if that has been introduced in our region. And actually we decided not to introduce that into the region. Again, that is a form that reflects patients' wishes and preferences and advanced care planning, but actually because we already have the suite of deciding right documents, we decided that we were using those and they suited our region better. So the respect form has similar principles, but we have decided to continue using the deciding right suite. So that's one thing that our region have been doing. Nationally, you may have heard there's been blanket policy about introducing DNA CPR decisions, and I'm really pleased to say that in our region I haven't heard of any criticism about that, and I think our clinicians are working to make sure, again, it's all individualised care planning. Thank you. Next slide. So those first of all are saying how we're already talking about advanced care planning. Another thing our region has been ahead of is supporting generalists managing patients, and many of you may be familiar with our symptom control guidelines that we're all currently in the 4th edition of these. These again were produced by a network task and finish group in response to generalists wanting more advice about how to manage patient symptoms. And so they asked for a small portable booklet that they could carry around with advice on symptom control and management of palliative care emergencies. So, and in fact, this has been, this innovative guidelines have been actually adopted by other regions. We've had other regions contact us asking if they could use them, of which, of course, we can. They're currently in their 4th edition and they're due for review in 2021. So again, network-led. Next slide, please. So again, another network approach, and this again by the network, a task and finish group for the network, wrote this document. So again, if we refer back to BWE, when she talked about the criticism of Liverpool Care Pathway back in 2013 and the one chance to get it right recommendations about how we should be caring for people at the end of life. Again, a network group led by the network, a task and finish group, got together and thought, how can we support generalists in prompting good care at the end of life, prompting conversations, prompting medical assessment, nursing assessment, and writing it all down in a document that everyone can see. And so the network group got together and wrote the Caring for the Dying Patient document, which many of you are familiar with. The content and the prompts in there aren't led by us. They reflect the national priorities, again, as BWE has said, the 5 priorities of care, the 6 ambitions. And for any of you who are familiar with the National Audit of Care at the end of life, if people use the document, it does make it easier to fill in, to complete the audit at the end of life. And again, in writing this, we had representation from multiple healthcare professionals from all localities. It's currently being reviewed, work led by Tracy Wilson, our programme lead, and we have almost completed that, reviewing the medical assessment, nursing assessment and ongoing daily assessment sections. And again, we will later be collaborating with the digital forums to digitalise this. Many areas have introduced this and also have put other information alongside, one of which might be the network prescription chart. And if I could have the next slide, please. And again, this is a network prescription chart, again, written by a task and finish group in the network. Although it's called a community prescription chart, it's actually technically an order to administer chart. So it guides if patients have been prescribed subcutaneous medication, this is a guide for the community nurses to administer that medication to them. And whilst initially it was designed to be used in the last days of life, it is now being used for any patient who needs any subcutaneous drugs. So it's used for patients who are not at the end of life as well. It can be used at any time. What for having been initially designed, it is now being developed that it can be used across when patients transfer care settings. So we're often find it completed when people come out of hospital into the community. So that's facilitating more rapid administration of drugs as need be. And some areas have actually moved it into an electronic document. Sunderland are doing have at the moment looking at electronic prescribing, and that's based on this document. So I note at the moment, I think the only electronic prescribing and administering we've got is done in some of the hospitals, and Marie Curie have also they are doing electronic and prescribing and administering on system 1. But I think in the community we're still in many areas not struggling to document administration. It will fully come when we have electronic devices in all houses. Next slide, please. This is about the ambulance service. And again, this is best practice, innovative. People don't have this across all the nationally, and we're very lucky that we have this innovative service in our region. And this service was funded by Macmillan, and Macmillan service funded service the North East Ambulance Service. And this was funded about 3 years ago, I think, if I've got that right. And Macmillan kindly funded a Macmillan nurse end-of-life care facilitator, Sarah Turnbull, a Macmillan engagement officer, Paul Galloway, and admin support, Chloe Ince. And the funding has allowed these Sarah, Paul, and supported by Chloe to provide more education into the ambulance service. They've encouraged advanced care planning, they've encouraged completion and registering of special patient notes and emergency healthcare plans and DNA CPRs. So they've got a lot of information that they've encouraged sharing from healthcare professionals and also sharing the paramedics going out. But they've also funded 3 end-of-life ambulances covering different areas of the region. And the aim of these end-of-life ambulances is to transport patients on their last journey and to arrive within a prompt and timely way, to arrive in to arrive within 1 hour, to transport them in a timely way. And I have to say this has been an excellent and very innovative service. Many patients have described very positive feedback, and we've heard of people being transferred from hospital via St James's Park and via the coast on their last journey. So I have to say, not only do they transport these patients, but they actually, it's very individualized service to for these patients on their last journey. Next slide, please. What else are we doing in this region? We are got electronic palliative care coordination system. So again, across the country, B and the national team have been promoting, trying to get electronic palliative care coordination systems. And again, we have been ahead with this, led by Dr. Catherine Hall, who is the end-of-life CCG, CCG end-of-life lead in North Tyneside, and she has leading on this project for the last 3-4 years, looking at an electronic coordination system. She piloted across practices in North Tyneside. It's now being rolled out across practices in North Tyneside, and what has been encouraging is clinicians to fill in information and have that accessible to Northumbria Hospital. At the moment, unfortunately, the money initially came from the network and then came from the national list. So, Catherine, whilst it's still being rolled out across North Tyneside, other areas, there will be lessons learned on that and can be shared with other localities, but no money coming from the network or centrally. And then just finally, so much going on, and we try to keep up with it in the network, but there really is so much going on. Other bits of work that we've come across is the 24 palliative care telephone advice line, and nationally they would recommend that all generalists would have access to 24-hour palliative telephone advice on palliative care. Unfortunately, this hasn't been commissioned across all localities, but many localities do have advice lines run by the specialist palliative care teams there. It may be the community palliative care teams, it may be run by the hospices, and this is so important in supporting generalists, supporting our out-of-hours doctor colleagues, supporting our out-of-hours nurses 24 hours a day. So, as I say, in many areas it isn't commissioned, and there may be some commissioners in this audience. I would like to ask you and please for you to think about commissioning this, because I think this will support high quality palliative care across the region and enable patients to remain in the place of their choice. Again, our national teams talk about availability of palliative drugs in the community. We would struggle to keep patients out of hospital and their preferred place of care and death if we didn't have access to palliative care drugs in a timely manner. And again, I've heard BWE asking for how this can happen nationally, and I am proud to be able to say, well, actually, we've been doing this for several years, over 10 years, up in the northeast, working with our local community pharmacists to agree a named supply of palliative medication and to agree for these to be stocked in some agreed extended hours of opening pharmacies, in order that we allow timely access to medication for our palliative patients. So again, we are ahead of perhaps many other regions in the country. Next slide. So I just wanted to finish off just by a case history. I'm not sure who's in the audience. There may be lots of people who would have lots of cases they could tell, but I just wanted to just show how this all fitted together, really, to illustrate. And there's so many cases that I could choose from this, and I think this lady just resonates with many people. So the case history I just wanted to talk about and just show you how it can work, and how it can work well if we do it well. There's lots of other cases we can look at when perhaps it's not gone as smoothly, but this is how we would hope it would be for many people who may be unfortunate to be diagnosed with a palliative diagnosis. So a 70-year-old lady diagnosed with esophageal cancer and metastases, decides for best supportive care and discharged from hospital. Having recognised the patient is palliative, we actually are now getting a lot of prompts. I note this is a Northern Cancer Alliance conference. We are actually getting a lot of prompts from oncologists now who have recognised the patient is palliative, starting those conversations and actually prompting out into the community for GPs to add patients to their palliative care registers, which is great that people are now starting to acknowledge that and starting to have some of these conversations. So the GP, having known that, went out and looked at symptom control, and again how does it work? We've got symptom control. If he wasn't sure about managing the symptoms, we've got the network guidelines. If he therefore couldn't manage symptoms further, then he could always ask specialist palliative care teams for advice. But again, we started off with the symptom controls, knowing that that would help many GPs with first-line symptom control. The GPs also started some advanced care planning conversations, and having recognised that the patient is palliative, has discussed and documented DNA CPR decisions, and also started talking about emergency healthcare plan and documenting that. So again, this is a GP that feels confident and competent in bringing in those discussions. And one thing I've missed out on the slide at the moment is that we do a lot of training of specialist palliative care on having those conversations and getting confident in and competent in having some of those seriously ill conversations. So again, that's what we would be hoping that GPs would feel able to do that. Add to the practice palliative care register, referring to the district nursing service. Many of our patients are managed very well in the community with GPs and the district nurses without needing the support of specialist palliative care. So all the palliative care patients should be referred to the community nursing services, that they're aware of them and they can support them and their families in the community. And again, the GP here has shared the information about the DNA CPR and emergency health care plans with NIA and with the out-of-hours services again. So in response to the NIA project and encouraging this, we're getting more of these special patient notes being shared. And again, if this patient was in North Tyneside, that information could be seen on Catherine's palliative care summary records. That's the type of thing that people will be able to access. Next slide, please. So the case history. So this lady then went on to have a bleed. The family called 999 and the patient, the NIAS was aware of the emergency healthcare plan and admitted this lady into hospital. And I've actually just put that in this example because, as I did say before, that often there's a misunderstanding that anyone with emergency healthcare plan would remain at home. It could have been a conversation that people had with the lady that she wishes to remain at home, and there may have been many patients who might have done, and then the emergency healthcare plan would have talked about how to manage the patient at home, what to do, who to call, and who would be there for support. But in this instance, it had been elected this lady wished to go into hospital, and so she did. And she went into hospital and she deteriorated, was felt to be dying. And again, conversations took place about where she wanted to be. Her preferred place of death was home. And then it was talked about how we would get her home. So again, in this best practice example, someone has had a conversation with her about where she wants to be. And they've started her on the caring for the dying patient document, again, with all the prompts about good conversations, good discussions, and the symptom control in that. She's also had injectable medications prescribed and written upon the community prescription chart. And again, as we've said before, now all this information can be transferred with the patient back out into the community. It doesn't need to, documentation doesn't need to be duplicated, and the questions don't need to be duplicated either. So again, the document is recognised across all care settings. The end-of-life ambulance was requested and now has arrived within 1 hour. So again, as we say, great practice. In the past, it could have taken, there could have been delays in getting drugs ready and delays in discharging and getting transport for the patient, meaning the patient might arrive home out of hours and late at night. But with the advent of our end-of-life ambulance, we're getting more people home during daytime hours. Next slide, please. And finally, in this case history, the patient continued to deteriorate. The community nurses supported the patient at home with the GP. The GP reviewed regularly using the network guidelines, and the patient died peacefully at home, with the death verified by the community nurses and bereavement support provided by the primary healthcare team. All along this is this case was to illustrate that much of palliative care can be managed by generalists at home, and it often is done. Specialist palliative care team will be there to help at any point, and should the primary healthcare team have wanted specialist support at any time, they could call them for advice, support, visiting, inpatient stay at any time. But this was just to an example of actually how GPs and community nurses have managed this patient. But actually, in this instance, they're supported by a lot of what's been done by the network in lots of the documentation, lots of the symptom control, lots of the strategic developments behind the scenes. So what went well with this patient? The patient was recognised as being palliative. There was proactive discussions, advanced care planning, proactive plans, sharing of information between services, a skilled workforce in order to carry out the care, using, documenting and sharing that the patient was dying. And that's how we managed to achieve and sharing between services, this patient dying peacefully in the place they wanted to. Last slide, please. And I'm proud to say this is a CQC inspection reports. When I've done this, I've realised I haven't written the title, but this is the inspection of end-of-life care and services across our network. And as you can all see, I think it speaks for itself. All trusts and organisations across our part of the region were good or excellent, which I think is fabulous and reflects the service that we carry out up here and that we're proud to carry out in our region. And that is finally just to say thank you. Are there any questions, anything anyone wants to share, or any comments? Just going to look at some of the questions. How can we avoid a postcode lottery for good end-of-life care? Should it be a basic human right? And to answer that, it should absolutely be a basic human right. And the way we avoid a postcode lottery is, I think, again, working together collaboratively across our network. It's working with the national team to share and learn from any best practice nationally. And I think we can do that. But I think in our region, we're very much ahead of and always have been nationally in most respects. And I think that is very much what we've wanted to do, to share good practice across the network, to share, to develop documents across the network, and to share good practice across the network, and make sure that we ensure that everyone has good end-of-life care. And what I love about working across the region is I think all the healthcare professionals work really closely together across localities, across groups, and I'm working now with GPs who it's great to see work collaboratively across their localities as well, and especially with this digital work. I'm realising there's a real network out there that people are helping other people. So it's lovely. Everyone seems to celebrate everyone else's success. They're happy to share their successes and happy for everyone to learn from each other.
I think thanks for that, Alexa. I think that gives the regional view on that question after Biwi's talk as well. I think there was just one thing I wanted to bring or ask. I think it was really good to hear a case study that demonstrates that this does work, because sometimes I think having those difficult conversations as generalists seems to be in the too difficult to do box. So it's really good to have that example of how it can work really well. And just, you did mention the Decide and Right education group, but there is a wealth of educational material available on our website, isn't there, under the Palliative and End-of-Life Care group, that people can access to learn more about Decide and Right and the other suites of guidance that we have across our network. So I just wanted to say thank you for sharing that case study, because I think it is what people want to hear, especially if it isn't in their everyday job to use these skills. So I just wanted
I would totally agree, Adrian, and I think what we're also learning is that everyone can help out. So different people have different skills, but actually it's sharing about them. So even if clinicians recognise that someone's palliative and let the community teams, the GP teams know, then the GPs can start to have those conversations, and then they can be picked up again by other clinicians. So everyone can start to have those within where they feel, where there's opportunities again, and where they feel confident and competent. And then it's really important we share that information, so we don't end up with the patient having to repeat conversations. They can develop conversations where they've started, but if we share that, then we know where the patient has got to left off, and other people can pick that up when the opportunity arises, or where they feel more skilled to do that. So absolutely everyone can play a part in this, within everyone can play a part within this, and within where they feel confident and competent about that.
Yes. And I think I just want to reiterate how within our region we do have a very well established network that feeds into all localities within our region. So we do have sharing events every year. I think we are a well connected network.
What I realise now, I've missed a slide out here. There's a lot of work being done north of Tyne, and there may be people on this group who want to comment, but the Northumbria and Newcastle trusts have got together with the hospices up there, and again looking at education and looking at supporting doing education up there and helping people. And one of their priorities is going to be teaching on conversations about the serious ill. So there's a lot of support for people there in communication, etc. Improving communication.
My question was to all of you, I suppose, is what opportunities do you feel that we have, and are we taking to understand patient experience of end of life and palliative care, and how do we use that information to improve what I've learned this afternoon is an absolute excellent approach that we seem to have in our region?
There's it's being introduced across various areas, and I know sometimes some people it's encouraged. Sometimes it can be difficult because asking, say, at end of life after the patient has died, you're asking the experience from the bereaved relatives, but I think quite a lot of areas are looking, and that's something that's some people are asking the bereaved relatives for their feedback from that. So I think there's various pockets to do. Example, I should know from the tip of me, and I'm going to ask at the network group next week about that. There's been the patient experience link down south of the river, hasn't there, Adrian, looking at patient experience within that. So you're right, it's really important we pick that up and then we can learn from that. As part of, I think GP surgeries are encouraged to get feedback from patients. I think often people can be reluctant with palliative patients, but actually palliative patients are really keen to feedback on their experiences. I don't know if anyone in the chat box wants to write what they do. I know in the organisation I work, Newcastle Hospitals, as opposed to part of the network, they do get feedback from patients and relatives once a year, and to look at regular feedback from them of the services in the hospital and community. I'm sure many of the organisations across do similar.
Alexa, it's Jo. I would agree with that, because I spent part of my career working for the Northumbria Healthcare Patient Experience team, and one of the things that we used to do was regularly visit our palliative care units, and it was always very surprising. I sort of really identified with that that part where you said that sometimes we're a bit frightened to ask for experience because we don't want to bother people, we don't want to encroach on a time that is obviously so precious and emotionally sensitive for people. But I was always taken aback how willing families and patients were to speak on those units about their experience and want to share. And I think sometimes we create our own barriers, don't we, in terms of worrying about upsetting people at a very, very emotional time. But actually, the reality is that the majority, not all obviously, but the majority of people were quite happy to speak and to share their experiences.
Yeah, I'm nodding here. Absolutely, I would totally agree. I think they're very happy and they want to give back and they want to provide learning for that.
Yeah, and Tracy's just saying there's also more less formal routes in terms of understanding patient experience. So it's looking at complaints and compliments. And I know things such as, it's not called that anymore, but NHS Choices, that's what was NHS Choices. That's a great source as well of information from people of learning and understand what experiences is. Thank you, Tracy. So I think that brings to a close our session this afternoon. Can I just thank Alexa for a wonderful presentation, Alexa, and again I would echo the same thanks that we gave to Professor Biwi. So thank you so much, Alexa.
Jo and Sue, I'd just like to say thank you to you for setting it up.
Brilliant, thank you, Alexa. And just to say a thank you to the audience as well, because we know these are very challenging times and pressure on our professional and clinical time. It's very precious, and it's not going to notice the fact that people have made time to attend these sessions. So as a Cancer Alliance and all of the presenters, we are so grateful that you're able to give the time to the learning event this week.